Good morning. My name is Kara Narrigan. I am here to do a video soap note on a patient that I saw this last week. Her name is JR. She is 74 years old and she is a Caucasian female. She presented to the office for her yearly physical and medication management refills by herself. Her chief complaint was for her medication refills and for her yearly physical for Medicare. JR presents to the office today for a yearly physical for insurance and medication refills on her medication for her DDD. She is pleasant mood today. She reports that her average pain level is a 4 out of 10, higher in the evenings depending on the activity throughout the day that can get as high as 8 out of 10. Since her last visit here in the office 4 weeks ago, she has had visits with her surgeon and her oncologist. She reports that she had some fissures that had caused her some rectal bleeding that she was treated for by her surgeon. She also reports that bleeding has subsided and that she has not noticed any in 3 days. She states that she followed back up with him 2 days ago with a negative rectal exam. She states that she is awaiting for the office to call her back with an appointment for her colonoscopy, as her surgeon is the only one that does her colonoscopies after an abnormal colonoscopy that she had several years ago. She reports that she followed up with her oncologist yesterday to get results of her mammography that she had completed 2 weeks ago. She states that there is no evidence of cancer and her next mammography will be in 6 months. She states that she did draw blood yesterday and her hemoglobin was 8.1. Upon questioning, she further states that she was told she needed to follow up with her primary provider regarding this. Here at the clinic today, JR reports no fatigue, shortness of breath, blurred vision, dizziness, ear pain, nasal congestion or drainage, nausea, vomiting, diarrhea or constipation, muscle weakness, unexplained bruising or bleeding. Due to her report of having a low hemoglobin, we will repeat her CBC, run an anemia profile, and a BNP here in the office today. The plan is to have the patient follow up in 1 week or sooner to discuss lab results when they result. Her past medical history includes breast cancer, DDD, hypertension, hypercholesteremia, CHF, overactive bladder, hypothyroidism, AFib, depression, and chronic pain. Her surgical history includes tonsils, bilateral breast lumpectomies, bilateral knee replacements, lumbar spine laminectomy, a cholecystectomy, a tubal, umbilical hernia repair, and portions of her colon removed. Social history: she lives alone. She has 3 kids. She denies any alcohol use, smoking use, or any illegal drug use. She does admit to 1 caffeinated beverage a day. Her family history: her mother passed away in her 80s. She had a medical history of CHF and an MI. Her dad passed away in his 80s. He had a medical history of cancer, and she does not have any siblings. Her 3 daughters are healthy. She is up to date on her immunizations. She is allergic to morphine. It causes her to have nausea, and Cipro, which causes a rash. Her medications include Norco, 7.25/325, 1 tablet TID, Abilify, 10 milligrams, 1 tablet daily, Baclofen, 10 milligrams, 1 tablet TID PRN, Zyrtec, 10 milligram, 1 tablet daily, Welchol, 625 milligrams, 1 tablet BID, Cymbalta, 60 milligrams, 2 tablets daily, erythromycin, 0.5% eye ointment, 1 centimeter to lower eyelid, TID, Pepcid, 20 milligrams, 1 tablet daily, hydrocortisone, 2.5% rectal cream, BID, PRN, levothyroxine, 0.125 milligrams, 1 tablet daily, Myrabic, 50 milligrams, 1 tablet daily, Lyrica, 300 milligrams, 1 capsule BID, Xarelto, 20 milligrams, 1 tablet daily, Zocor, 10 milligram, 1 tablet QHS Topramate, 200 milligrams, 1 tablet BID, Ambien, 5 milligrams, 1 tablet QHS. Under the review of systems, she denies everything at this time. Under general, she's alert, NAD, non-toxic. She denies any eye drainage, itching, blurred vision. ENT, she denies ear pain, nasal congestion, and drainage. Respiratory, she denies shortness of breath, non-productive cough. Cardiovascular, she denies any chest pain, extremity swelling, or palpitations. Gastrointestinal, she denies any nausea, vomiting, diarrhea, cramping. Urinary symptoms, she denies all of it. She denies any frequency, urgency, hesitancy, burning, or odor. Musculoskeletal, she denies weakness and fatigue, muscle cramps. Neurological, she denies any dizziness, headaches, confusion. Endocrine, she denies any increased thirst, unexplained weight loss or gain. Her skin, she denies any rashes, sores, or dry skin. She denies any bleeding or bruising. She denies any SI or HI. And she denies any allergy symptoms at this time. Objective data, her blood pressure, her vital signs. Her blood pressure is 124/76. Her pulse is a little tacky at 98. Respirations are 18. Her temperature is 96.4 orally. However, she did just drink some cold water prior to her temperature being taken. Her O2 saturation was 97% on room air. Her height is 68.5 inches, and she comes in at 156.3 pounds. Her BMI is 23.4. On her physical exam, it was unremarkable, except for that she was pale. Her skin was warm to the touch. She had no bruising. She had active bowel sounds in all quads, with no masses. Cardiovascular, her rate was regular, without any murmurs or tachycardia. Her chest showed, her respirations and everything was normal. She had no complaints of shortness of breath, which really kind of surprised me, with her hemoglobin of being 8.1. However, with her having her bleeding, she may have been low for a while, and her body has adapted to it. In the office today, we are actually going to draw an anemia profile, a CBC with DIF, and then a BMP. So my differential diagnosis for this young lady does include iron deficiency anemia, chronic or acute blood loss, and neoplasm, just because of her history. But I'm going to go ahead and I went ahead and I diagnosed her and treated her for the iron deficiency anemia. While we were waiting the blood work to return, I advised her to go ahead and take a iron supplement pill, 325 milligrams once daily. I instructed her to take the tablet with orange juice 1 hour prior to eating, preferably in the morning before she eats breakfast. I told her that we were drawing the blood work in the office. She agreed to that because we wanted to see what her levels were from yesterday to today, and that I would like to see her back in 1 week, unless her blood work came back sooner, and then I would give her a call and have her come into the office sooner. And she agreed to that plan. I saw her on a Monday. On a Tuesday, her lab work was called back as critical. She does have iron deficiency anemia. Her hemoglobin did come up to 8.9, so it came up a good bit, from the day before. She was 8.1 per her recall from the doctor, her oncologist. So I was proud to see that. The hematocrit came in at 30.9. Her MVC was 76. Her MHC was 21.9. Her MCHC was 28.8. And her platelets were awesome at 324. Her red blood cells came in normal at 4.07, and her WBCs were 7. So with the anemia profile, her TIBC came in at 509, so she was a little bit elevated on that. Her UIBC was 494. Again, it's a little bit elevated. Her total iron was 15. Her iron saturation came in at 3%, and her ferritin came in at 18, which was normal. Her vitamin B12 also was normal at 479. So what we did is I went ahead and called her back on the phone, and instead of having her come back into the clinic that day to go over her labs, I went over them on the phone with her. I increased her iron to 3 times a day, the supplement, 3 times a day. I educated her on the importance of taking it an hour before she eats, and taking it with the orange juice, as the orange juice helps the iron be digested more and absorbed better into the system. I still wanted her to come back in 1 week because I wanted to check on her and see how she was doing. It'd be a real quick visit. And then after that, I told her I wanted her to come back in 4 weeks, so that way we could recheck her blood work and see how she's doing. So the diagnosis and plan was to increase her iron. I also, because of her history of the fissures and her not being on any type of stool softener, I wanted her to go ahead and start the Senna S. It's over the counter. Start with 2 tablets every night, since we're going to be increasing her iron and there is a chance of constipation with that. I didn't want to cause issues with her fissures. I told her that we would like her stool to be a consistent soft, not diarrhea, but more on the softer side than on the harder side. I advised her that she could increase the Senna S to 2 tablets in the morning and at night if she needed to help keep that stool at that consistency. If needed, she could also back down all the way down to 1 capsule daily to keep that, so that way we don't give her the diarrhea. She verbalized understanding. We will have her return back to the clinic every 4 weeks, and we will redraw her blood work every 4 weeks to make sure that her iron levels are coming back up. Once her iron levels are coming back up, it can take up to 6 months for her iron to get reabsorbed back into the body and into the bone marrow where it needs to be. So we will continue treatment for at least 6 months after she gets to a therapeutic level within her blood. She verbalized understanding and agrees to the plan, and we will see her back in 4 weeks.